Actually, we're planning teleneurology and talking about beyond telestroke. That may have to be changed at the last minute. We're kind of in a little turmoil over that right now, but if things do change, we'll certainly let you know what's coming up. Welcome to our Adobe Connect window. Just want to show you a couple of things with my lovely green arrow here. You'll see the participants list. Just below that, you'll see a number of files that you can download for your uses. And one is today's presentation. And there might be a couple others that Martha puts up, although we usually have a save the date card for our next conference, but seeing as we just had one, we'll probably let that rest for a little while. Down in the bottom, web links pod, you'll see a link to our new website. If you haven't seen our new NRTRC website, we encourage you to take a look. We think it looks pretty good. And a link to SurveyMonkey to take a little survey on your impressions of today's presentation. We actually, Martha has found a way to put the survey on your screen at the end of the day, so we will put that up there and encourage you to fill it out. You can tell us what you thought of today's presentation, as well as tell us subjects you would like to see covered in our ongoing webinar series. You know, we're here to serve you as much as we can, so please let us know what you'd like to hear about, and we'll do our best to schedule it. The chat pod is a place where you can speak with each other, send messages back and forth. If there are any technical issues that you encounter during the day, please put your statements there, and Martha and I will keep an eye on that and try to fix whatever comes up. To the left of that is a question and answer pod. You can type your questions in at the bottom of the pod and hit your return key or your enter key, and Kim will see your questions as they come up. She may answer them on the fly if it's appropriate at that time, or she may wait till the end of the presentation. It's entirely up to her. And then just a couple notes over here on the far left to give you some ideas about how we're proceeding today. And as far as our introduction goes, I had to confess to Kim a little earlier that I lost her official bio. Well, I didn't lose it. I was in meetings all morning and couldn't find it when I got back. But I first saw Kim present, probably 2 years ago now, at the National Rural Health Association meeting in Seattle. And she was talking about a little program going on down in North Carolina, the Roanoke Chowan Community Health Center, doing some remote monitoring with chronic disease management. And I was really impressed to hear her speak at that point. A little bit after that, she talked with one of our colleagues over in Virginia, Kathy Wibberly, at the Mid-Atlantic Telehealth Resource Center about doing a project that I ended up getting involved in, and that's the Central Oregon Telehealth Network. Roanoke Chowan is mentoring Mosaic Medical in Oregon into building a remote monitoring system replicated on the basis of what Roanoke Chowan is doing. And this is really an exciting project. So I'm glad that Tim agreed to speak with us, and I'm waiting to hear her. So Kim, take it away.
I understand that there's a little bit of echo on some folks, so if I hope it gets corrected. If not, just keep opening up in the chat. I am open for questions on the fly. Used to doing that. I told Bob that I could talk about this program. I've been forced to talk about it in 4 minutes, and I've spoken as long as 5 hours on it. So narrowing it down to about 40 minutes is a pretty good option. So I don't mind being interrupted. I'm been doing this project in remote patient monitoring. This is our 8th year, so we're pioneers as a community health center. We're an FQHC. Probably most of you know that we're a federally qualified health center. That's what that means, and we're fairly new on the horizon as the history of them go. We're about 9 years old, and we're in eastern North Carolina. So I'm going to move my slides down here, go on to the next slide, and see if I can find my arrows. There we are. That's we were a federal ACA FIP funded project, and so we in our little area in northeastern North Carolina. I'll show you the map here in just a second. We were awarded a facilities improvement grant in the amount of $6.2 million, and so we went from 27 exam rooms in our main campus site with 11 providers at the time to 48 exam rooms. So pretty exciting as a primary care provider. We do all the things that most community health centers do. We are integrated fully in behavioral health. We have oral health in our partnership with East Carolina University School of Dental Medicine integrated into our program. And we do all kinds of crazy things to keep our operations going, just like most of us these days, and trying to navigate this healthcare whirlwind we're all in. So this is where we are in eastern North Carolina. If you've ever been to North Carolina, and you can see where I pulled out our counties, we're a U.S. Congressional District 1. We are the 4th poorest U.S. Congressional District in the nation. Most folks get surprised when they hear that. But this is very a rural area, not quite as, I came from New Mexico, so I know a little bit about frontier. It's a different kind of rural area, although we're only about 45 minutes from Hampton Roads, which is the Norfolk, Suffolk, Chesapeake, Virginia Beach area. It's full of generational poverty issues and high disparities, healthcare disparities, and just a lot of issues. And you know, when you work in a poor area, those things that are evidence, cardiovascular disease, diabetes, hypertension, and they are killers here. So we have 100 counties in North Carolina, and on all of those areas we're in the 90s for morbidity. So it's hard stuff, and you see the median income there. It's just the challenges. So when we came into the scene as a community health center about 9 years ago, we said we got to do something. And I came with a little bit of a telehealth background from New Mexico, and worked there in telepsychiatry with some folks. And if you're familiar with ATA, you'll know Dale Alverson's name. Worked a little bit there with him in the project, and in eastern, southeastern New Mexico in a community behavioral health center that expanded into primary care and telepsychiatry. So when we came to North Carolina, I was fortunate enough that one of my nurses, Bonnie Britton, was very familiar and a pioneer herself in remote monitoring. And so we said, let's integrate this into primary care and see what we could do using remote monitoring as a tool. So I'm assuming, since you're part of the, a little bit familiar with telehealth, and you know what remote monitoring is. And so I made that assumption in this, but we can go back if anybody has a question. So it's basically biometric monitors engaged in the home. So scales, blood pressure, glucometers, pulse ox, and then we use branching logic questions and several tools. PAM measures, the PHQ-9, and just specific policies and procedures related to chronic disease management. So we started a program just in North Carolina, funded by, it was tobacco money at the time, and that was, our state was given, and reconciliation for the abuses of tobacco in our area. And so it was called the Health Wellness Trust Fund, and we were able to start locally with our program in 2006. And given a little grant and gauge the change in cost of the product, one home set at the time, which was scales and the monitor itself, and which was about the size of a telephone at the time, and blood pressure cuff and the pulse ox, it was all about $5,000 for purchasing. So today that same set of equipment is about $700. So a big change. So our second telehealth remote patient monitoring network grant from the state was to expand and replicate what we had done in our community health center. And I'll talk a bit about that in a minute. But we were able to expand and replicate our remote patient monitoring, engaged with the primary care and the patient at the center. In fact, we called it the patient provider community telehealth network. And so you can see we have various hospitals, other community health centers. Solid Foundations is a community behavioral health center. We had a specialty heart institute in there from East Carolina. And we crossed the whole state, which was very cool, and replicated this within multiple electronic medical records, as well as even a health center that did not have an electronic medical record at the time. So we were able to move on and balance that program. The program existed for 5 years, and then the administration changed. The majority House and Senate and the governorship changed after over 130 years, Democratic to Republican, and they just did not refund the project. So we're in the process of reevaluating this on our state's level, and I'm really optimistic they're going to be able to come up with a solution. Our current network partners are what Bob was referencing, and that is this next slide. And the COTN is the Central Oregon Telehealth Network, and we've been funded twice back to back with HRSA, OAT, that's the Office for the Advancement of Telehealth network grants. So our first one was with the slide I showed you prior, and the second one is with the Central Oregon Telehealth Network. So we have no, that does not involve at all any engagement in North Carolina, but it does involve a public-private and network partnership. So we're part of the OCHN network, the Oregon Community Health Information Network, that's based out of Portland. And so Mosaic is a community health center that's a part of they call them CCOs in Oregon, or ACO, and that's the COHC there. That's the Central Oregon Health Connection, or that's their name for their CCO. And then InScope Health, which is a private, for-profit entity that does, they primarily have been in defense and energy contracting, but they actually have their expertise in analytics and scaling on a national level, and marketing and promotion and development. So that's one of our partners involved in there. And then we have included the Mid-Atlantic Telehealth Resource Group, as well as the Bob's group as well too, which is great. So this is the first time HRSA has ever done a bi-coastal project, so it's pretty exciting. And then as well as having the public-private partnerships in that. So the whole point of the project is to be able to scale the project on a national level, and then be able to increase the communication, meaning that we intend to be able to cross electronic medical records, because there's multiple ones in the project. They're not all Epic-based as OCHN is. So that's one of our main goals in the project. So it's pretty exciting work, I have to say. And we're in our first year, so we have 75 patients enrolled right now, which is amazing. Their group is amazing, and I'm going to talk about that in a minute. And then we also are working with InScope on a private venture in order to sustain our program in North Carolina, because we do not have a reimbursement on a fee-for-service yet, or on any other kind of payment for our remote patient monitoring for our existing patients. And so InScope is out there coordinating business with the self-insured market, brokers, and several other organizations that some folks in the exchange and co-ops that are developed in 27 states. And so we've got some pretty exciting things going on. And then they subcontract with us to do the monitoring. And we're also working with the state of Virginia. Western Tidewater is a community health center and health department that covers in the Hampton Roads area. So we're working with them on expanding their network as well too. Next slide talks a little bit about the Central Oregon Telehealth Network. So, of course, the ACA is at the center. You can see all our partners in there. And this is a 3-year project that we hope to be able to cross the data across multiple sectors, and also be able to have some good decision-making and integration with electronic medical records for the primary care provider and the patient. So we are actually going to Oregon next week to do our second site visit, and meet with the analytics and IT teams of the partnership of the ACO, CCO there, and work on some discoverable items that we can address the issue. What's really, really exciting about this project is that we're opening ourselves up to the social networking on this. We have a blog, and I think I'll give you that address here as we move along. And we also have a Twitter site, and we're tracking our successes, our challenges, the opportunities that we've come up across, some of the variables we've come across, and I'll talk about those here in a minute. And we're blogging those and tracking those. And the Mid-Atlantic Telehealth Resource Center is actually funding an intern to kind of keep that tracking. And we've got some surveys out there that are monitoring people's impact and impressions and monitoring our patient satisfaction surveys and all the scales that we're using. So hopefully the outcome of this will be that anybody can replicate the program and learn from our challenges and opportunities and also gain from our successes as well. So this is the framework, and this is what we've been using really from almost the very beginning. So there's a picture of the equipment there. It's pretty small, but frankly, the equipment's pretty small. It's stuff that you would see in your home. It's Bluetooth connected. We in the telehealth project in Oregon are using off-cell equipment. So they primarily connect to a Verizon pod, just like your cell phone does. So it's plugged into an outlet. So just for electronical connection, or it has battery. So whatever's the stronger connection. And this particular pod actually has the ability to get the stronger strength. So if they have another server, if it's an AT&T or another server, they can pick that up. In Oregon, it is Verizon, and they are remote. The primary clinic that we're working out of is Prineville, outside of Bend, about 45 minutes outside of Bend. And the first patient we installed was another 45 minutes into the mountains outside of Prineville. So definitely one of those frontier sites, and we were grateful that we had rented a four-wheel drive vehicle to do the installations. And they needed the Verizon pod, and we're able to use that. We also have plain old telephone lines that we can hook up as well too, and we've done that with several of their folks, but it's primarily cell. So everything's Bluetooth. So the scales are in the bathroom. We encourage the patient to use it just as their natural course of the day. We encourage them to do it by a certain time in the day after they take their medications. So scales are in the bathroom, that they take their weight. The equipment holds the report until the next report comes in, which may be their glucometer reading, or it may be their blood pressure, or it may be the pulse ox. Then once it has everything together, it automatically collects it and transmits it through encrypted internet access to a centralized location. You can see the nurse there that monitors the equipment, monitors the report, and we can also tell if someone hasn't done it. So we call that the compliance factor. So we get a data report that is red, green, yellow, that kind of tells what a patient is doing. We have one nurse monitoring on a daily basis the outcomes. So each patient has their own individualized plan of care and their own metric. So if my blood pressure isn't an issue, but my sugar readings are, as we say here in the South, our sugar reading, we actually can individualize that plan of care. So that's how an alert is generated. Is there still an echoey tone? Is it better? I'm just double checking. I'm seeing some remarks there, so I'm making sure. I moved my mic a little bit, hoping that helps a bit. Maybe that's a little better. So if there is an alert and the patient's parameters are out of scope, they will get a call from the nurse that's monitoring, and that nurse has some standard questions that she'll ask. She'll make sure that they've taken their medication. She'll follow up with some specific questions because she knows that patient, and make some recommendations. If there's a sequence or a pattern, for example, the best scenario I can give is a patient with COPD, and we see a trend that they may gain a little bit of weight and the blood pressure's moving up over a course of 3 or 4 days. Well, that would be an alert, and we would notify a primary care provider. We would do that through either their nurse or triage, or however that primary care provider indicates, either by direct contact. In Oregon, the nurse does the direct contacting, and so she's the triage for the patient and then goes directly to the provider. So that's really a preventative focus for this program is engaging the patient, giving them the opportunity to respond, and helping them have a teachable moment at that particular time. I'm actually a psychotherapist by trade, so understanding that this is kind of biofeedback, they see something that might have happened the day before, and they immediately see the impact and the outcome of that. We also touch base with the patient whether they've had an alert or not at least once a week, and we use that also as teachable moments. So we have a format and structure. If they have diabetes, for example, we'll talk a little bit about the DASH diet, or we'll talk a little bit about sodium levels, or we'll talk about something that's related to improving their outcome. And then also give them an opportunity to ask questions. After a patient has been on for we've seen a pattern after they've been on for about 4 to 6 weeks, if their readings are outside of the parameters, because they know what they are, we talk to them about that, they generally call us. About 60% of the time they're calling us when there's an alert, which is great. So we've become a part of their care team, and it's very patient-centered. So you see there a picture of our Dr. Jones and his bow tie there and one of our patients. And so literally, he can see that almost immediately when it comes down. And the patient actually, I have this picture here because the patient actually has the perception that their provider can see that every day. And of course, they don't unless there's an alert, but they have the ability to see it if they choose, which is very cool. Right now, we don't have it integrated into our Epic system, and that's basically because we just paid for it recently to do that, and we're trying to decide what data needs to go in. Some patients take their blood pressure, for example, 3 times a day. Do we really want 3 blood pressure readings in the EHR? So there's some components to that is a part of this project that we're in discovery about of what's the best thing to put in the electronic medical record for the provider to see that the patient is current, if there's an alert, if there's been a trend. Every 2 weeks, we do generate a report on trend analysis, a brief summary report on highlights of what's going on with the patient, and that does get sent to the provider, and that is made a part of the note. We're working with Mosaic right now on how to use the patient portal also to use that as part of our communication back and forth. And that has actually been one of our best solutions in our community health center since we don't have as many options in using remote monitoring as we're just using it for our critical patients right now. We used to have about 150 patients on. We have now about 40 patients on, and that's just because of the affordability of managing the equipment, and there's no reimbursement currently. We have no grant to cover it. What we've done is when we step down the current patients, we step them down to MyChart and the patient portal, and they give a notification on a routine basis to their primary care provider through the patient portal, which is really cool. A little hard to trend yet, but we're working on that. Because the trends are very important and gives good feedback for the patient and the provider as well too. So this is basically the methodology as we're figuring out what for each individual program can be done. This is in coordination with InScope on this project. How we can go to the next stage of deciding what the technology might be, the product and selection. We have multiple vendors. We are vendor neutral. There's a lot of vendors out there. There's some that are not very reliable. There's some that are. We primarily use 2 right now. We use Idealife. It's a company based out of Toronto, and we've been working with them for about 6 years. They have a very affordable project, very reliable, and right now they're the most reliable Verizon vendor. We also use Philips, which is almost 100%, I would say, reliable, and the equipment is extremely sturdy and productive. They just developed a cell pod. They don't have Verizon yet, but I know that it's coming. Theirs is a little higher in cost, and I think some of it has to do with because they're so large and they have such production. They don't put it out unless they know it's 100% reliable, and that's helpful. But they range in cost for our whole set, which would include a blood pressure, scales, and pulse ox and glucometer, and you can get any range of other things. There's peak flow monitors. We aren't doing an asthma project now, but there's remote monitoring peak flow monitors. But for the basic chronic disease management that we're doing, you can run anywhere between the $750 to $800 to about $2,000, depending on who you're using and what you're using. And that's a very broad range, and as I mentioned, there are a lot of providers out there. So this is what we measure basically right now in most of our projects and with our individual plan of care. So the clinical indicators are there. We also encourage a home visit as we do the setup and monitoring so that we can gauge the safety of the patient's home, their access, their ability to be able to use the equipment. We have a standard kind of, we have them show it to us 2 or 3 times while we're there. We test the equipment there, and that's pretty reliable. We also are monitoring the number of primary care visits, the hospital bed days when we can, and mostly we can only do that on Medicaid right now, working on doing that cross-sector, as I mentioned, with our analytics, ER visits, and then contacts by the monitoring nurse, the frequency of that. And then our clinical indicators are right there as well, what you would probably expect. And then our first 3 years of our major program that was in-house, part of our project grant was independent evaluation, and our evaluator was out of Wake Forest School of Medicine, and specifically pulled the data from our 80% of our patients are part of what was then called University Health System, but they changed to Vidant recently. So we just pulled charge data. So these are 64 patients that we pulled the data on that were using remote patient monitors. So we were able to pull 6 months prior to installing remote patient monitoring. So you see that number there on hospital bed days. And then the 6 months they were on telehealth with us, remote patient monitoring, from day 1 to end of the 6-month period. And then for 3 years we monitored those patients as well after the 6 months. So they only stayed on the remote monitoring for a 6-month period. So we monitored their impact of their cost data and their bed days. So you can see that those 64 patients had 199 bed days prior to telehealth in that 6-month period. During telehealth, it went down by 50%. What was most amazing is that they maintained that over a 6-month period. In fact, improved on it. Same with ED visits, and I will tell you those 5 ED visits during remote patient monitoring, those 5 visits, 3 of them were one patient. So we didn't separate that out by that. So also they were able to maintain that ED over the 3-year period as well too. And then the hospital ED charges. So you can see prior to remote monitoring, the 6 month it was 1.3 million, and then during telehealth it was 382,000, and then an 87% reduction post 3-year post. So that's just that same data basically by hospital days, emergency room visits in a graph chart. So this is a quote from about 3 years ago from Wall Street Journal when everybody was looking for some value-based solutions. And amazingly, everyone believes this. Everyone believes this data, but there's still these huge barriers for folks diving in on the shared savings component of utilizing remote patient monitoring. I think there's some anxieties about related to how potentially this can be abused. You know, I think that there's some issues that are surrounded with that. And I also think there are so many people with so many issues going on right now in healthcare changing rapidly that's a challenge. So it's been really important to us that you use data, that you do comparison and analyzing of the data, and that's the core and basis for our Central Oregon Telehealth Network grant. I used to say, and Bob probably remembers, I said, you know, this really isn't rocket science. If you're monitoring one of your patients based on their individualized plan of care, based on what you want to see with that patient, using equipment that we've tested and that's reliable, you're going to see an improvement. And that's true. That part of it isn't rocket science, but how to implement, how to choose the vendor, how to troubleshoot, how to get the schematics correctly, how to decide what level of intervention is needed, all of that over the course of the last 8 years, we've been able to really figure out some various degrees of engagement with remote patient monitoring to get the best outcomes. And then actually using the network and has been really, really helpful in getting the feedback. And I will tell you that there's already a keen difference in working with a state that has expanded Medicaid and is highly resourced for their most vulnerable population compared to a state like us that isn't, in North Carolina. And for example, our nurses, our RNs that are our remote patient monitoring are associate level RNs. The nurses in Mosaic are bachelor level RNs. The depth and the difference in engagement of diagnostics and trends and impact and solutioning is marked. And I'm really looking forward to getting some of that data and understanding how to best utilize this information. So how do you pay for it? And we already saw this quote earlier, but there are multiple states. There's a great map right there that show the states that are currently have a, and that's just as of 3 weeks ago. So that's pretty current on the states that do have a remote monitoring, various type of reimbursement. Most of them are fee-for-service, although the recent trends I read are more in the shared savings model, a PMPM, or an additional payment if you use remote monitoring in your toolbox. And I really like that much better than I like the individual fee-for-service. Nothing happens in a vacuum. It all has to kind of work within itself. Emerging trends right now, of course, everyone knows the aging of the population, that we're living longer. In this, the baby boomers, we're living longer. We want to age in place. No one wants to go to a nursing home, and how do we do that? The wireless impact, we still have some real issues around that on connectivity, what kind of bandwidth. In our area here, it's so funny. We work with about 6 or 8 different vendors that want to work with us, and they send their equipment to us. In fact, Intel sends their equipment to us to test all the time because they figure if it can work in northeastern North Carolina, where we have no AT&T service here and got swamps and all kinds of things to get in the way, if it can work here, it can work about anywhere. So we testing of equipment. The efficiencies in being able to get the data right back to the patient and to the provider, it just is incredible. And industry alliances, that's a big word for ACOs and what's going on now with the advancement of the Affordable Care Act. And the cost effectiveness. Who is actually saving the cost? So when you look at that data about our hospital emergency room visits and length of stays, our community health center didn't benefit from that. Now the patient benefited from that, and the health system benefited from that. So our local health system, that mentioned Biden earlier, actually adopted a continuum of care telehealth remote monitoring program. And they utilize remote monitoring for their high-end utilizers of the ED and post-discharge patients that they feel might be at high risk. So they have about, at this point in time, about 2,000 patients that they're monitoring over the last 2 years. And they monitor them from 30 to 90 days. They're trying to get them from being a bounce back within 30 days, readmission. So they've actually, were a partner in one of our projects, saw the outcome right away within a year and a half, dedicated several $1 million to advancing this program. We then partner with them if there's a patient that's one of our primary care patients. They actually use a case management model, meaning that everyone who has diabetes fits into the same metrics. And they don't individualize their plan of care, and they don't connect that information back to the primary care provider yet. They tell the patient, you need to contact your primary care provider. Fortunately, we both use Epic, and the hospital's connectivity is Epic, and we have a component called Care Everywhere, and so we do use that for connectivity, and that's helpful, and continuity of care. So the healthcare market emphasis on patient experience, everybody knows what we're talking about when we say patient centered medical home. This is a great patient engagement component, the teachable moments, the patient learning, immediate feedback on what happens when they don't take their meds, or one of the trends we saw right away, and Mosaic's experienced firsthand, is towards the end of the month, the patient's blood pressure starts to creep up. Well, the first question you ask is, tell me about your medications. Well, I don't get my check until the 3rd, so I'll start splitting my pills. Well, that's exactly the wrong thing to do, and especially when you have a chronic disease and you need the medication. How do we address that, and what do we do? So actually connecting them in a community health center setting is really helpful to someone that can help with medications. What do we need to supplement with samples? What can we do to bridge that for the patient? And, get the pharmacist to just give 5 days till the 3rd, and then, all those kind of things that you can case manage that patient's. So individual issues that are going on. And you can only do that if you have a good relationship. And really, no matter what tool you're using, no matter how efficient it is or how great the technology is, if you don't have a relationship with a patient that is trusted and valued, and gives that same trust and value to the primary care provider, you might get a little bit of outcome, but you're not going to get the outcomes that we got. And that's the key to this, is there's one nurse case manager assigned. One nurse case manager can monitor about 75 to 100 patients, and that's the same person. And then you have someone that's also helping with compliance and troubleshooting equipment. But they're a care team, and just like your primary care provider is part of that care team as well too. So economic resources, government pressure, that's I think why we scored 100 on our application, I have to say, from HRSA, thanks to our partners and engagement in that process. They want to see that something like this can be integrated across multiple systems, including the EHR, efficiencies with patients in a medical home, the emerging trends of utilizing the real meaningful use of a medical record, and the key collaborations of the multiple specialists, hospital, anybody that's involved in touch that patient, including their family members. So we have proxy options in our medical record as well as in the equipment use. Whoever wants that data, if they want it, they can get it electronically if the patient authorizes that. So if it's my mom in Pennsylvania and I've got a remote monitor equipment in her home, if she gives me that permission, I can go to my email, it can go to my smartphone, it can go those same alerts, and I can get the trend reports every 2 weeks as well too, so that we can engage that, broaden that circle of the patient care. And their specialist or anyone else that patient authorizes and is a part of the recommended care team. And then, of course, the emphasis on error reduction and how the affordability of our, how we pay for healthcare these days, on the options of decreasing our staffing models. So if you can save this page, I'm not going to link onto these videos, but there's a couple of really nice videos in here. The first one is a little shorter. It's about a 4 to 5 minute one. The second one is a 7-minute video that tells a little bit more, and you actually get to hear from the patients and see our patients firsthand and see them using it in the home, which is really kind of cool to be able to have that experience firsthand. And then you can follow us on our Facebook page. We have some information about how to connect to the our COTN blog, and that's advancing as we speak right now. So here's our mission and an expansion of our project, and leveraging our best practices. Staying neutral in this platform, and I say this even with vendors in the room. Vendors overpromise and underdeliver, and so it's taking caution when you sign up with a vendor. As you know, if you're dealing with telehealth as we go across the line, it's so important to be able to know that they're reliable. I see Bob just put up the blog spot on there. Thank you, Bob. Appreciate that. And then it's so important to develop partnerships. The value proposition is right here for the patient or employee. We do self-insured market, so that's where this slide comes from. And I've already kind of explained that patient component. It's so critical. And then the provider. Initially, we had some folks that were anxious about, how much information am I going to get? How do we engage in this? And now we have 22 providers in our organization. Every one of them could be what I classify a remote monitor champion, because every one of them knows the value of getting that information, finding out the window of what's going on at home when they can't come to the practice. One of our groups out of North Carolina, Greene County Community Health Center, is a migrant seasonal farm worker health center. 85% of their patients are sliding fee. And even with the ACA, they are still under 200% of poverty. The majority are under 200% of poverty. And really, really struggling. And how they use their remote patient monitoring was those folks could not afford even their copay, but they needed to know what was going on in between times. And so these folks often only came in once a year, twice a year at the most, but they could install this equipment in the home and find out what was going on between visits, because they really couldn't get them in due to transportation or work barriers. And then also this equipment, the two vendors we use now also have Spanish options. They have multiple other language options. We only use the Spanish, but they do have other language options too. So it will give the prompt to the patient in their native language and come back to us in English, which is great because we don't have those native language pieces on there. So that's great for us. We also have the employer wellness program. We utilize that in-house. We have a kiosk that each of our employees, and we do this in the wellness market with the brokers and the self-insured, they have a password protected on the individual plan of care, and the kiosk just is Bluetooth connected. Looks like one of those things you see at CVS that has everything attached to it, but it's your individualized plan of care. And that information can either stay with that patient and they can track it themselves. It can be loaded up to a centralized server and go to a nurse to monitor, or it can go right back to the primary care provider. So that's really kind of a cool component. Idealife has the best kiosk, I have to honestly say, all the ones that we've seen over the course of time. How we can get you started if you want to work with us on this kind of a project, define what your organization needs. We were working with a group out in New Mexico just on Monday. It's a co-op, and so, they already have a partnership using community health workers that go out to the home. That's perfect. We can engage those community health workers to do the installations. And the troubleshooting of the equipment, if they want to do their own nurse monitoring, we can do that. We can help train, teach, and set up. If they want us to do the monitoring, we can do that as well, too. If they want us to help track the analytics, of course, they're in cross systems with a centralized co-op insurance agent, component piece to it. Do they want to keep that analytics? They want to keep that separate? Do they want to go to the primary care provider? They want to have it centralized in there? Are there incentive bases to that? We're working with a group, Clean Trekking. If you've seen them out and about there across the whole country, it's I think a $28 billion company, and we're monitoring their dependents as well as the actual employee. And they've incentivized them that if they'll stay on the program for 6 months, after that 6 months, for a full year, they'll cover all of your copays. So there's various programs, and one of the other groups that we work with, another private company, they if you completed the program, the 90-day program, they added $500 to your self-insured plan, meaning that your health savings account had an additional $500 in it. So there's all kinds of components as you're working on how to develop a program like this. There are multiple grants out there, especially as you're doing in the safety net. We could not have done it without our grants, and also adding the value proposition of how to get this into a culture of the meaningful use of electronic medical record, and then how to do delivery and support and the analytics. I've got a Q&A here. So any questions that come out of that, I'm glad to do that. I leave this one as our last, and other than my information, because you have to develop key partnerships. And over the course of the last 8 years, these are all the groups that we've worked with that either funded our project or funded the specific end of our project, or we're currently in funding right now. So really, really important to gather in multiple resources and multiple folks that can help you in a project like this. So we've really, really been fortunate, and when you're especially working in vulnerable populations, it's so key to have partners that know your population as well too. So I'm glad to entertain any questions, anything I can help y'all with, and if I think Bob has there's who I am and my email address. Bob has all of our information too, and you've got the blog spot now, so you can see that as well.
I've got all that contact information, Kim, and we'll be putting the recording of today's session up on our website as soon as it kind of filters its way through our Adobe Connect server. And everyone that's listening is welcome to download the slides right now in a PDF format just by clicking on the telehealth presentation link in the files pod. If you have questions for Kim, go ahead and type them in the Q&A pod. We'll wait a few minutes to see if anyone wants to ask you anything. But Kim, I just want to say I certainly do appreciate your taking the time to be with us today, and I'm really glad to be participating in the Central Oregon project with you and Mosaic Medical. It's really an exciting project, and I look forward to seeing a big expansion of remote monitoring in the future.
Me too. I'm trying to open up Joe's question, and it only will say, "Would you indicate it?" So I don't know if you can see. Can you see Bob's? Bob, can you see Joe's question?
Not seeing any questions at all, Kim. Oh, here we got one. Um, Yeah, we've got a couple. Joe Humphrey, one of our emeritus board members and a physician who lives in Hawaii, asks if you have any partnerships or interaction with health plans.
The health plan component is with the brokers, so we don't have any managed care organization partnership right now. We actually work with United Healthcare on some of this. They haven't taken the bite on it yet. Blue Cross Blue Shield is actually doing some in-house work. The closed health plans like Kaiser and Group Health, they've been doing remote monitoring for a while. The VA also has been doing remote monitoring within their system, as you all probably are more aware of it, familiar with them. Also, have been using remote monitoring. So the closed systems, yes. The managed care, not so much yet. And Deborah has a question too, and let's see if I can get this to open. Click to expand.
Yeah, I can get that for you, Kim. She's asking if you'd indicate again what Medicaid resources you have used.
So depends on if they've expanded Medicaid. So in this, there's I think 16 states. That graph is kind of small, but it's from ATA. I think there are 16 states right now who actually have, that's in the gold, that actually have a remote monitoring, either a fee-for-service or a PMPM with the Medicaid. I just read Maryland's, and they are just now allowing RPM as, if it's ordered by the primary care provider, and then the equipment has to be purchased by the patient. So there's various sundry Medicaid options, and as different as every state is, every Medicaid plan is different. In Oregon, of course, it's the ACO model. So RPM is an allowable cost in their CCO. If you are a Medicare ACO, RPM is an allowable cost as well too. So that's really encouraging. And those that are expanding as an ACO in Medicare, that's one of the cutting edge pieces of remote monitoring now. I hope that answers your question, Deborah. She's saying something about Florida. I don't know why it won't expand my question.
I'll go ahead and read them for you, Kim. Between there, Joe asks what the cost per patient is per month for the services, and do you have any estimate of total cost?
So that it varies by vendor. So it averages somewhere for just the server and the equipment. And we don't buy equipment anymore. We lease the equipment. Initially in the project, you didn't have any options, but you had to buy equipment. And as I mentioned, that initial cost. So that was very, very cost prohibitive. In leasing equipment now, you have better options. And if you work with a group that will allow you to lease, with some contractuals on that, which Idealife, we've been leasing and working with them for the past 3 years. It ranges from anywhere, the combination of server and lease fees to between $75 and $120, I'd say, is probably the range in there for leasing and the server cost. Depend on the server, and right now I don't know about this divestiture of the um, phone services. We only have one server. It's CenturyLink, and um, they are they will not budge on their server fee. So it ends up being about just the server fee is about $35 to $40. So that's the individual per month cost on that. So to the patient right now, there is no cost in any of our programs right now to the patient. And so that's what we're trying to figure out what's the reimbursable cost on that. So I think one state has, they actually reimburse $8 per day for remote monitoring. One does $16 per day. One does $40 per month, and then the server fees on top of that. So there are some that do $75 a month. There's some, it ranges on up the scale to about $250 a month, depending on the number of alerts. So the cost piece of it is, it's all over the map, and it's hard to answer that question. Deborah's asking something about in Florida, and really there's a great population need there in Florida for sure. But Bob, can you tell what her question is?
Yeah, Deborah commented that parity is unlikely in Florida this year. Looks like the legislature is not going to pass it.
Right.
And then
Right.
Joe's
Stay
got another
correct.
question.
Mm-hmm.
Are you reporting out quality metrics? HEDIS
We
metric,
are.
L, A1, PC, BP?
Yes, I think we have a graph on there, the things that we're measuring. Um, there you go, on what we measure. So patient satisfaction, and we actually do provider satisfaction. We use the patient activation measure survey to gauge it's called the PAM, to gauge the health literacy of the patient so that we know how to target our relationship impact to the patient. And then compliance, meaning that are they doing as we've done ask them to do. So we ask them to maybe monitor, not every day, but 3 times a week and do it before noon. Are they doing that? So we measure compliance. And then the personal cost. We actually did an anecdotal cost analysis where patients just gave us what they thought that they were out of pocket with medications and co-pays for emergency room visits and things like that. And this was very anecdotal, and the N was only like 15, but these patients estimated that by using remote monitoring, they probably saved out of pocket up to about $3,000 a year, just because they didn't have to pay their 20% co-pays in the hospital and the emergency rooms, and actually reduce their medication use and PCP visits. So, and then of course the clinical indicators are right there as well too. A1Cs, LDL, BP, weight, glucose, and O2 sats. And then the health services use, that's in our grant that we're monitoring right now, and the medical cost. Those are the things that we acknowledge are the high cost. We want to add use of medications. We do that in the Central Oregon grant. We are monitoring medication use as well too. I don't know why we didn't put that on there, but we're monitoring medication use, utilization.
Is there any further questions for Kim? Go ahead and enter them. Have you seen improvements in the clinical indicators, Joe asks?
Oh yes, significant, and I don't know why I'm missing that graph on there. On the A1C and the blood pressure and weights, the weight part of it, we're dealing with COPD patients and chronic disease patients, 2 or 3% reduction. But in the blood pressures, we're averaging about 20 to 35% reduction in blood pressures over the course, if they've been on the course for 6 months. And on blood glucose levels, actually saw a 44% reduction, and A1Cs as well too. So if they stayed on the program and complied, and for 6 months, those are the kind of indicators we're getting. It's basically daily coaching, so from a nurse, and you track this information, you give them a picture of what they're doing. So yeah, that's the plus in this, and then of course the monetary plus from the hospital impact on the health systems. That's the biggest factor. Estimating over the course of those 64 patients, if we factored just the hospital cost, estimated that we saved over $4 million over that course of 3 years of that patient use, the patient cost.
And once we get those
And
data,
thank you.
we'll put them on
Yeah.
the blog site too.
Mhm. Well,
Any other?
thank you all so much. I appreciate it.
Well, Kim, we really appreciate your taking the time to be with us today. Martha has just taken over control of everyone's monitor and put our survey up. Please just take a few minutes to respond to that survey. Let us know what you thought of today's presentation, and let us know what you'd like to see in a future webinar. Um, we are here to serve you, so you tell us what you need and we'll try to bring it to you. And with that, thanks everybody for joining us, and thanks, Kim.
Oh, you're welcome, Bob. Thank you all. Nice to visit. Take care.